Hey there, and welcome to the first lecture of All About Neurology. In this episode, we'll dive into some keyword parts, just like we usually do, focusing on combining forms. But today we're going to take it up a notch by adding some important suffixes, along with abbreviations and acronyms, and you'll definitely want to know these. So let's go ahead and get started. Things off with our first combining form, somato, which refers to the body. You've probably heard it before in terms like psychosomatic, which relates to the mind and the body. The next one we've got is gustato, which is all about taste, or more specifically, the ability to taste. Then there's audito, which is related to hearing. And finally, olfacto, that's the combining form for smell. We'll dive deeper into how these senses play a role in neurology in just a bit, but just to recap, we had somato, which means body, gustato, which means taste, audito, which means hearing, olfacto, which relates to smell. All right, let's go and keep going. Now let's move on to a few more combining forms. First one on this slide is encephalo, that refers to the brain. So anytime you see this in a word, it's about the brain itself. Cerebro, not the computer from the X-Men, but here cerebro is for cerebrum, which is the largest part of the brain. This is um, pretty straightforward because you can already see the word cerebrum in it. Then we've got cerebello, which refers to the cerebellum, the part of the brain responsible for coordination and balance. And finally, on this slide, we have cranio, and cranio is a combining form for the skull. It's all about that protective bony structure that houses the brain. Again, to recap this slide, it's encephalo, which refers to brain, cerebro, which refers to cerebrum, cerebello, which refers to cerebellum, cranio refers to skull, and let's continue. Keep going. Let's go over a few more combining forms. So the first one on this slide is meningeo. That refers to the meninges. The meninges, which are the protective linings around the central nervous system. This will come up more in our next lecture, so stay tuned for that. Um, Neuro, this is a simple one. It just means nerve. Don't overthink it. It doesn't specifically refer to the brain or spinal cord, just the nerve itself. Next up, we have radiculo, and it doesn't mean ridiculous. Right? Radiculo and rhizo. These are two pretty similar combining forms. You'll often see them used interchangeably. Both refer to the spinal nerve root. So whether you see radiculo or rhizo, they're essentially pointing to the same thing. So let's go ahead and recap what we learned in this slide. Meningeo, which refers to the meninges, those protective linings of the central nervous system. Neuro, which just refers to nerve. Radiculo refers to spinal nerve root. Rizzo, there's a singer. Sorry, my mind goes somewhere else. Rizzo refers to spinal nerve root. And yeah, that's it for this slide. All right, let's break down these next combining forms, starting with aphero and ephero. Right? I'm going to try to really stress that so you can hear the difference. Aphero, A-F-F-E-R dash slash O, and ephero or ephero, E-F-F-E-R-O. Right, you want to learn these two terms together. So they're opposites of each other. So aphero means to go toward the center, which is from the periphery toward the central nervous system. When we dive into anatomy and the different pathways in the body, this concept will come in handy. And then on the flip side of that, ephero, right? E-F-F-E-R-O, means to go away from the center or out from the central nervous system to the periphery. So if you learn one, you can easily remember the other because they're two sides of that same coin. Next up, we have esteto and or esteso. And both of these relate to sensation. You might recognize anesthesia in this context, which means a state of being without sensation. So when you get a general anesthetic, you lose the ability to feel pain. And with a local anesthetic, you wouldn't be able to feel the stitches, for example, being placed. Then there's phaso, which relates to speech, and phago, which refers to the act of eating. So let's go ahead and recap what we learned in this slide. Afro, I'm going to just pronounce it with the long vowel, aphero, which means toward the center. Ephero or ephero refers to away from the center. Again, I'm just pronouncing the long vowels to make sure you understand the difference in the spelling. Okay, the next two are esteto and esteso, which refers to sensation, phaso, which refers to speech, and phago, which refers to eating. These are some important ones, so take your time with them, and let's keep going. Let's push through a few more combining forms. First, we have here ischio, which refers to blocking or restriction of blood. Right? This will come up in cardiovascular chapters, but it's important here as well. There is ischemia, like a blockage. It can lead to what's called an infarction, which is the next combining form. So the next combining form is infarcto, which refers to an area of dead tissue. This is when there's a blockage, like in ischemia. It can lead to the death of the tissue in that area, and that creates an infarction. The next combining form is plego. This relates to weakness, and we'll dive deeper into this when we get to our health and wellness section. It's something you'll definitely encounter when talking about conditions like paralysis. The next one is sclero. This refers to hardening. So you've probably heard of sclerosis, an abnormal hardening condition, right, of say blood vessels or other tissue. You've heard of multiple sclerosis, right? This is a disease that we'll cover in this chapter, and you'll also see sclero again when we talk about the cardiovascular system. And the last one is icto, which means seizure. And we'll talk more about this when we get to epilepsy and other seizure-related conditions. Let's go ahead and recap what we covered in this slide, right? Ischio, which refers to block. Infarcto refers to an area of dead tissue. Plego refers to weakness. Sclero refers to hardening. And icto refers to seizure. So we're almost through here with this first part. Let's keep it up. Good work. All right, let's break down some important suffixes. The first up is cele, C-E-L-E. This suffix refers to a herniation or an abnormal protrusion of tissue. In this chapter, when you see the suffix cele, it's usually going to be talking about a herniation. You'll see some examples and illustrations in the upcoming sections to make this a little bit more clear. The next one is cephalus. This simply means head. It's pretty straightforward, referring to the head or a condition involving the head. The next one is glia. This is an interesting one. It literally means gluey, or refers to something sticky, a sticky substance. So in the next lecture, we'll actually go a little bit deeper into glial cells, which are a type of nerve cell that provides support to the nervous system. So glia is all about the support structures of the nervous system. And then we have lepsy, which means seizure. We'll cover this again in more detail when we talk about epilepsy and other seizure-related disorders. And lastly, omatosis, the suffix omatosis. This one is a bit of a mouthful. It combines two suffixes you've already learned, osis, which is an abnormal condition, and oma, which refers to tumor. So omatosis refers to an abnormal condition involving tumors. All right, let's go ahead and recap what we covered in this slide, right? Cele refers to herniation. Cephalus refers to head. Glia is gluey, those supporting cells. Lepsy refers to seizure. And omatosis is the abnormal condition of tumors. And that's the last of our suffixes for now. So again, you're doing great. Just keep up the great work. All right, now let's take a look at some important abbreviations. So first we have CNS, and I'll try to my best to actually pronounce and enunciate each letter. So CNS, which stands for Central Nervous System. This refers to the brain and the spinal cord, which together make up the body's main control center. We also have CSF. This is short for cerebral spinal fluid, the clear fluid that surrounds the brain and spinal cord. It helps cushion and protect both of them. Next up is CVA, right? It stands for cerebrovascular accident. And this is a medical term for what we commonly refer to as a stroke. The next abbreviation is EEG, and this can refer to either an electroencephalogram, which is the actual recording of the brain activity, or electroencephalography. Remember, when it ends with the Y, it's a process. So an electroencephalography is the process or act of recording the brain's electrical activity. Okay, so when you come across the abbreviation, you'll be able to tell whether it's talking about the recording itself, which is the gram, which is the image, or the process of recording, which is graphy, right? Gram versus graphy. And that's based on the context of the sentence or the paragraph. Okay, finally, we've got ICP. This stands for intracranial pressure. Hopefully I pronounced that and enunciated it very well so you can hear it. This refers to the pressure inside the skull, which can be an important measure in various neurological conditions. So let's go ahead and recap what we covered in this slide. CNS stands for central nervous system. CSF stands for cerebral spinal fluid. CVA, that stands for cerebrovascular accident, otherwise known as a stroke. EEG, which stands for electroencephalogram or electroencephalography. And ICP, which is intracranial pressure. Remember, context is key to understanding abbreviations. Keep practicing, and it'll start clicking. Let's cover a few more abbreviations to wrap things up. So the first one here is ICP, which you said stands for intracranial pressure. We're repeating this one. And it's the pressure inside the skull. Again, I'm going to go ahead and recap. This is an important measure for conditions related to the brain. And we will come across this in discussions about like brain injuries and other neurological issues. I didn't realize I repeated that one twice. LOC, in your textbook, that stands for loss of consciousness. But I've mostly seen it used as level of consciousness, right? So loss of consciousness in your textbook, also a level of consciousness out in healthcare. So this refers to a person's alertness or awareness. So for example, if you're well rested, alert, and functionally normal, you're at a good level of consciousness. But if you've had surgery and are under the effects of anesthesia, you might have a lower level of consciousness, feeling groggy or sleepy. The next one is LP. That stands for lumbar puncture. Right now, my mind is going back to the old vinyl records. I don't know why I'm thinking LP. I couldn't tell you what it stands for when it comes to vinyl records. But in the medical term, it stands for lumbar puncture, and this is also known as a spinal tap, which is the name of a band. So this procedure involves inserting a needle into the lower part of the spine to collect cerebrospinal fluid, CSF, remember, and they collect that for testing. The next abbreviation is MMSE, and that stands for Mini Mental Status Exam, which is a tool used to assess a person's cognitive function. We'll talk more about this in our health and wellness lecture, as it's commonly used to evaluate conditions like dementia. Lastly is TIA. This stands for transient ischemic attack. Sometimes this is called a mini stroke. This is a temporary blockage of blood flow to the brain, and it's considered a warning sign for a potential future strokes or a CVA. To recap, in this slide, we covered LOC, level of consciousness or loss of consciousness, LP, which is lumbar puncture, otherwise known as a spinal tap, MMSE, which is a mini mental status exam, TIA, which is a transient ischemic attack. So great job for sticking with it. Keep reviewing these and you'll get them down in no time. Awesome. So these are definitely the most common abbreviations you'll need to focus on. So don't stress about the others for now. You've made it through this first part of the lecture and you're already on your way to mastering the material. So one more time, I want to say great work. And now we'll dive into the second part, which we're going to cover anatomy. And I'll catch up with you soon to break that down. Keep up this great progress. So I'll see you in a few seconds, a few minutes, or a day, depending on how much time you spend between these parts. And welcome back, everyone. This is the second part, lecture 2, and today we're going to be diving into this chapter of neurology. Now, if you've already taken anatomy and physiology, you probably remember that this system can be a bit complicated. There's a lot of minutiae here. So, in fact, there's so much of it, tons of details, intricacies, and layers of information, right? So let's go ahead and be real. You might not be super excited about this topic. I am. Hopefully I'm giving off that impression that I am excited about the topic. If you taken any of my live lectures, you'll definitely see and you'll grasp my nonverbal communication of excitement in these lectures. But if you are excited and you don't need me to, hype up the material, that's awesome. And I say this because I don't want you to dread it. So don't worry about all the little minutia. I've got you covered on this. I want you to approach this with a fresh perspective. So remember, this is not that full-blown A&P grind. And even though I know some of you are taking A&P at the same time you're taking this course, it's just supposed to be synergistic and help you. The goal here is to build a strong foundation so that the terms and concepts you're learning actually mean something. It's like the low-calorie version of A&P. And hey, if you haven't taken A&P yet, I hope I'm not like scaring you off. This is just the perfect starting point to get you comfortable. So when you do hit those A&P classes, you'll be ready to tackle it with some confidence. Alrighty then. I've been wanting to do that for a while as I transition from slides. Instead of saying, all right, here we go, I wanted to say, alrighty then, let's break down the function of the nervous system. This is actually an incredible organ system, and it's got a few major roles to play. So you remember that we discussed the skin's main functions? Let's go ahead and now focus on the key functions of the nervous system, right? It's the system that's always nervous. No, just kidding. The first up, we got sensing, right? So this is where the magic begins. Think of afferent neurons, the AFFER. And remember, we just went over the combining forms like affero and efero. And again, I'm enunciating them incorrectly, but only to stress the long sounds of the A and the E. Right? So the prefix affero, that means to go towards the center. And so when we talk about sensing, those afferent neurons are working hard to bring information from the outside of the world to your nervous system. So for example, if you put a cup in the microwave and that say it definitely isn't microwave safe. And as you reach to grab it, your hand gets hot. That's why we have microwave safe dishes. Um, and so you touch it and the dang thing is super hot and you instantly feel that heat. So that's your afferent neurons and pathways sending that hot feedback from the environment straight to your brain. And that's how your body senses and reacts to the world around you. Next, we need integration, and this is where interneurons come in. So acting like the middleman in the process, these neurons take the information from the environment and help process it. So think of them as relays that take what your afferent neurons send and then prep you for the next step. Finally, we have the reaction. So this is where efferent neurons and pathways come into play. The prefix efero, right? That means to go away, to go out from the center. So these neurons send out the commands for action. So in our example, as your brain processes the information, your efferent neurons will take action. So if you're too slow to react, you'll pull your hand back and avoid burning yourself. Sorry, if you're not too slow to react. So the cycle goes like you sense the heat, your interneurons process the information, then your efferent neurons trigger the right reaction. Yeah. So let's go ahead and sum up what we just discussed. I'm always going to try to do a little recap now from here on out. So we talked about sensing, which is related to the afferent neurons, integration, which is related to the interneurons, and then reaction, which is related to the efferent neurons. So that's the basic rundown of how your nervous system works to help you sense, process, and respond to the world around you, right? Nice and easy, right? We'll leave it there. If you want to study neuroscience, yeah, it's way, way more complex, but this is all you need to know. All right. All right, let's dive into the cells of the nervous system. Alrighty then. And here's a picture of a neuron. It's not really a good neuron. This is the one that was created by PowerPoint, right? So it's not a real picture of a neuron. It doesn't even look like a real neuron, but it kind of resembles one. So it's a neuron, right? It's a basic functional cell of your nervous system. And neurons are the real workhorses where they come in different shapes, sizes, depending on what role they play. So different neurons play different roles. So there are some exceptions, and this is there's some exceptions to what the neuron looks like, right? But this is the layout for most neurons. You'll have that cell body, and you'll have an axon that normally extends out. That's just going to reach out to another um, nerve or another neuron, and at that head or at that cell body, you will have those dendrites that actually are used to connect an axon from a previous neuron to that neuron. Right? Yeah, and sorry that picture is not an actual picture of a neuron. Um, I may change it one day, but it's a cool picture. All right, so at the center, what we talked about, the cell body of a neuron, right? It contains the nucleus. So just like every other cell, a neuron it's a cell like any other cell. Um, and so the control center of the neuron is located there in the nucleus. So from that cell body, you'll see dendrites, again, like I said, that'll extend from that cell body. They look like tiny little fingers sticking out, little suckers, or at least that's the way they're drawn on in the textbook. And these are structures that receive information from other neurons or other external stimuli. Then there's that long axon that I mentioned, right? That acts like a highway for those electrical impulses to go straight down, and it's going to actually activate another neuron or a target organ. So at the end of that axon, you'll find what's called an axon terminal or terminal bulbs. And these are responsible for transmitting the signal to the next neuron, or again, like I said, to the target organ. Now, some axons are located in a fatty substance called myelin. They're coded. Did I say they're located? They're coded in a fatty substance called myelin. This is known as myelin sheath. Right? I like to um, describe them as like hot dogs. They kind of look like hot dogs on the axon. Um, Hot dogs, corn dogs, maybe corn dogs because the corn dog's got a little stick sticking out of it. But think of it like an insulator around an electrical wire. The myelin helps speed up the transmission of those electrical signals, and it makes processing the signal more efficient. So without it, nerve signals would travel much slower. Okay, let's go ahead and clarify a little bit about neurons before we go to the next slide. So neurons are the cells that conduct impulses. They're the ones that get information from the environment, processes it, and then sends it out for reaction. Again, the example was you sense a cup that's too hot and your neurons go to work, making sure that the message and the action happen, right? And so again, plus neurons aren't the only players here. There's a whole other category of cells in the nervous system that helps keep everything running smoothly, but we'll get into that shortly. But for now, just remember neurons are the key cells responsible for transmitting electrical signals throughout the body. All right, if you made it through this slide, good job. This is a long slide. This is a long intro. All right, let's talk about glial cells in your nervous system. Hopefully you remember what glial stood for, right? These are the supportive cells that play a crucial role in keeping everything running smoothly. Glia is just that general term that we use for support, right? Support cells. So first up here we have microglia. As the name suggests, micro just means small, and that's a great hint about their size. So microglia act as the body's cleanup crew. They work to get rid of pathogens and illness-causing bacteria and other stuff that might make their way into the brain. They're essential for immune function within the nervous system, and they make sure that the brain and the spinal cord stay protected from infections. All right, the next one on the list here is oligodendroglia, the mouthful there. It's kind of fun to say, oligodendroglia. Uh, you try it, right? So oligodendroglia. It's cells. These are really important cells. The term dendro refers to a branching structure, while oligo refers to a few or scant, right? These glial cells are involved in forming that myelin sheath I talked about around the axons that's used to help speed up the nerve signal transmission. And there's still a lot that we're learning about these cells, but we know that they play a big role in the physical structure of the nervous system. So then there is the next term here, astrocytes. And if you remember the word astro, there's well, I'm going to be bad at this. There's a baseball team called the Astros. All right. I'm not a big sports viewer. Uh, Houston Astros. If I get this wrong, yeah, laugh. Just laugh at me. Yeah, astro refers to stars. So these are cells that they're shaped like stars, or at least that's what the anatomists think about when they see these. So they have a real cool shape, but it doesn't really tell you what they do, right? Other than what they look like, and the name. That's all. That's all the information you kind of get from the name. But what they actually do is pretty important. Astrocytes, they're essential for forming that blood-brain barrier. So this is that barrier. It's like a physical shield that protects the brain from harmful bacteria, viruses, and keeps you from picking up things, microorganisms, excuse me. So think about it like this. So let's say you get a sinus or an ear infection. Sorry about that. I got to turn that thing off. So you get a sinus or an ear infection, right? And you ever wonder why that doesn't spread to the brain, right? It's because it's in your head. Um, and that's because of this blood-brain barrier, and it controls which molecules can pass through, and it keeps all the harmful stuff out. So this barrier is why the central nervous system infections are rare. However, there's a catch. So that same barrier makes it really hard to get medication into the brain. So if you've ever needed medication that needs to cross the blood-brain barrier, it's a challenge. It's pretty tough. Um, yeah. So this is good and bad. And let's go and do a quick review of what's on this, what we covered in this slide. Glia, we mentioned glia, there are supportive cells of the nervous system. Microglia are the immune system's defenders in the brain. Oligodendroglia, these are those myelin-forming cells that help with nerve signal conduction. And then the astrocytes, those star-shaped cells that form the blood-brain barrier. I gotta like really enunciate that. And so these glial cells are essential for maintaining the health and function of your nervous system. All right, this is a very long slide, so if you made it through in one shot, congratulations. Let's go to the next. Okay, here's a quick visual overview of the nervous system. This is a super helpful image. For me, it is. It's if you're a visual learner, we're all visual learners, but if you lean more on visual learning, I hope it helps you out. So you'll notice there are two main parts, the central nervous system, the CNS, and the peripheral nervous system, the PNS. So the peripheral nervous system includes all the afferent pathways which are responsible for bringing the sensory information to the CNS, the central nervous system, right? And these pathways are like messengers carrying data from the outside world to your brain and your spinal cord or through your spinal cord. And then we have those efferent pathways, um, and these pathways carry motor commands from the CNS, from the central nervous system, and they tell your muscles and organs what to do. So, for example, after your brain processes information, like sensing that hot cup of coffee, hot cup of water. You know what? Hot cup of noodles. I'll just say noodles because I've been making some ramen noodles lately. So yeah, you put some noodles in a cup, you whatever, boil it, and you get that hot cup, right? So the efferent pathways send out the signals to act like pulling your hand away, right? We're going to dive deeper into this soon, but this is just a high level view to help you understand the structure and the hierarchy of the nervous system and how it works, especially if this is all new to you. This diagram is pretty basic. All right, so here we are going to talk about the central nervous system, or the CNS. And this is made up of two key components, the brain and the spinal cord. And we're going to break this down further. The cerebrum, right? This is what most people think of when they think of the brain. It's divided into two hemispheres, so that sparks any memories. The right and the left hemisphere, and the hemisphere just means half. So each side controls the opposite side of the body. So, for example, the right hemisphere controls the left side of the body, and the left hemisphere of the brain controls the right side of the body. So this is an important concept, especially when we talk about conditions like strokes later on, where a stroke on one side of the brain can affect the opposite side of the body. The next term here is cerebellum, and often we call this the little brain. It's located at the back, the lower part of your brain. The cerebellum plays a huge role in motor control and coordination. So it helps you with things like balance and fine motor skills. It is the reason why I can't play basketball very well. All right. It also helps your body know where it is in space, so how you orient yourself in space. I don't mean outer space. I mean like in 3 dimensions, right? So basically, it's responsible for what's called proprioception, and that's your body's sense of position. So are you sitting down? Are you sitting up? Are your legs, touching the floor? Um, all of that. Right? Or are you laying down? Are you laying on your stomach? Are you laying on your back? It'll help you orient yourself. The next thing is the brainstem, right? So the brainstem is the crucial link between the brain and the spinal cord, and it's in charge of vital reflex center. So these things are things that control things like the heart rate, breathing, basic life functions, things that you want automated that you don't want to be thinking about, like contract heart, contract again, or breathing, right? You want to go to sleep and have all those things happen automatically. So without the brainstem functioning properly, you wouldn't be able to sustain life as it manages your automatic processes. Um, it reminds me of automation engineering. So like everything we've engineered, none of it's new. There's like not a single thing that we've ever engineered that's like so new and unique. Nature's already done all of this. Okay, spinal cord is the next one. I won't get into any side topics. The spinal cord connects the brain to the rest of the body, and it carries signals between them. So it serves as that like I mentioned before, the highway for communication, sending sensory information up to the brain and motor commands down to the body. And of course, each of these areas has a lot more complexity and detail than what I'm talking about here. But this is, again, just a general overview to get you familiar with the main structures and their functions in the CNS. Okay. And in your A&P classes, you will go into more detail, much more detail. The central nervous system, CNS, this is surrounded and protected by several supportive structures, starting with the vertebra or vertebrae, plural, right? These tough, bony structures, they form this protective shield around the spinal cord. And what it does is that it ensures that it stays safe from physical damage. Right. Next, we have the meninges. Right? These are the 3 layers of tissue that cover both the brain and the spinal cord. I mentioned meninges when we went over combining forms earlier, and let's go ahead and break this down a little further. So we have the dura mater, right? The word dura means tough, and then mater, M-A-T-E-R, means a mother in Latin. So dura mater is the outermost, toughest layer, and it acts like a durable outer layer of protection for both the brain and the spinal cord. The next one is arachnoid mater, and the term arachnoid, right, comes from the Greek word for spider. And that's a good visual to keep in mind. The arachnoid mater is a bit thicker than the pia mater, but thinner than the dura mater, and it has a web-like appearance. So it does look like a spider web. So I've had the privilege of dissecting cadavers, and I've gotten to the point where I've separated the layers, the dura mater from the pia mater, and I've been able to expose the arachnoid mater. And it does look like the Halloween spider webbing that you buy at the store, right? And it pulls apart kind of like that. Um, right? So the last term is pia mater, and the term pia means tender. And again, mater means mother, so pia mater is the innermost layer, and it's delicate and it's close to the surface of the brain and the spinal cord. So very, very gentle, that making contact with those 2 organs. But between the arachnoid mater and the pia mater, which is that space that's filled with fluid, there is something called the subarachnoid space. And this is where, again, I give it away, cerebrospinal fluid resides in that little space. And again, speaking of CSF for cerebrospinal fluid, um, what is it? Where does it come from? Right? It's produced in the ventricles of the brain. Now, we said the word ventricle, or you might know the word ventricle from another organ, um, like the heart, but again, it's a chamber within the brain, and they're also known as ventricles. And within the cells that line these ventricles are there cells that create the fluid, right? So CSF has 2 primary jobs. One is that it cushions the brain and the spinal cord. It protects them from injury, like a shock absorber, and it serves as a delivery medium. So I must try to use the abbreviations more often. The CSF helps transport glucose and oxygen to the brain, and which again both are essential for brain function and they're essential for cell function. So they do this while also carrying away metabolic byproducts. So since the brain runs on glucose and oxygen, the CSF is vital for keeping it well nourished and functioning at its best. So between the tough vertebrae, the protective meninges, and the cushioning CSF, your CNS, central nervous system, it's well protected and supported, I would say. All right, so that was a quick overview of the central nervous system, CNS. If you had A&P before, I hope that served as like a nice low-key refresher. Let's go ahead and move on to the peripheral nervous system, the PNS, which is a little bit more complex. The PNS is made up of two main subsystems, and one of those is the autonomic nervous system. It has even more subsystems within it, right? It can get a little overwhelming, but if you've taken A&P, you'll know why. But that's exactly why I've just got this simple illustration to help you visualize it, keep it straight in your mind. And let's go ahead and dive into those subsystems. The peripheral nervous system, PNS, right? It's divided into two main subsystems, which are the somatic nervous system and the autonomic nervous system, which I just showed you in that slide. So let's break these down. The somatic nervous system. I'm trying to enunciate a certain way so you can visualize the word, and then I'm mispronouncing it too much. Somatic nervous system. The word somatic, right? That comes from the Greek word soma, and that just means body. So somatic nervous system is responsible for controlling voluntary movements of your body, like walking, talking, picking things up. It deals with the parts of your body that you have conscious control over. Then you have the other part, which is the autonomic nervous system. And autonomic comes from the Greek autos, right? Think of like a car, but it just means self, and nomos means law, right, or governance. So autonomic nervous system controls things that happen automatically, like your heart rate, digestion, breathing, things we mentioned a little while ago, right? Things that you don't want to be responsible for. You don't want to go to sleep and forget to breathe or your heart forget to pump. You want these things to operate continuously. It's responsible for regulating involuntary functions of the body. So essentially keeping everything running smoothly without you having to think about it. And the best way I can explain it is think about when you go to sleep, all the things that your body does to keep you alive. You want all that moving while you're asleep. Again, each of these systems, they play a key role in how your body functions. So with the somatic nervous system handling all the voluntary control and the autonomic nervous system being not being given, but taking care of the rest, managing the automatic processes. Let's go a little bit deeper here. The somatic nervous system, right? We say that controls the voluntary muscles, specifically skeletal muscles. So, for example, when I'm talking with my hands, like I normally do, and I'm doing that right now, without really thinking about it, my hands are just moving. Um, And that's how the somatic system works. So it's responsible for actions we consciously choose to do, like moving your arms, walking, or even blinking. Right? You don't have to think too hard about it. It just kind of happens. On the other hand, the autonomic nervous system, it handles involuntary muscles and functions, right? And these are things that you don't need to think about, like your heart beating, you digesting food when you eat, breathing, right? Like I said, these processes happen automatically, whether you think about them or not, whether you're awake or asleep. And they're controlled by the autonomic nervous system to keep your body just functioning without you having to actively focus on them. And so, a quick recap: in short, somatic refers to the voluntary actions that you control, and autonomic refers to the involuntary actions that happens without thought. Alrighty then, let's go ahead and continue with the somatic nervous system. I remember controlling voluntary actions, right? And it involves both what are called cranial nerves and spinal nerves. So your textbook is going to have a full list of these nerves. Don't worry. I'm not asking you to memorize all 12 cranial nerves or list every spinal nerve. It's good to know that there are 12 cranial nerves. Um, and they each are responsible for a particular function. But what's more important is understanding um, what these nerves actually do and how they fit into the somatic nervous system, how they fit in the bigger picture is what I want to say. So remember that the focus is on the fact that somatics, I want to pronounce this correctly, somatic nervous system, right? It's responsible for voluntary movement and things that you can control, like moving your muscles when you decide to walk, talk, or make some kind of gesture, like I usually do when I talk. So knowing the exact names of the cranial nerves and spinal nerves, that is helpful. It is useful. I just don't need you to do it for this class. You'll have to know it later on, like in your A&P. So again, don't stress about it. But we are going to talk about them. But don't think you're going to have to memorize them. I just understand the nerves they're part of the system that allows voluntary control over your body. So that big picture stuff. All right, just want to go back to this image here so you can get a quick review. Put this image in your head before we get into the next slide. So going from that larger image on the previous slide, now moving down to these smaller systems, we're going to talk about the autonomic nervous system and kind of break that down. Again, that's responsible for those involuntary processes in your body, and they're things that you don't have to think about, like your body's automatic functions to keep you alive, running smoothly, and as we mentioned before, like your digestion, breathing, um, um, the other things like your gallbladder releasing bile after you eat something that's really, really fatty, right? You want that just to happen automatically. It senses the fat and it releases bile. All that stuff happens without you having to think about it or controlling it, right? I don't think, I don't know of anyone who controls their gallbladder to release bile. Right? You can manipulate it by eating a lot of fatty foods, but that's not the same thing. So that's all the work of the autonomic nervous system. Again, managing those smooth muscle activities, respiration function, and you don't even notice it, which is the way it should be, the way engineering should be. Um, but within the autonomic nervous system, there are two key branches, sympathetic and parasympathetic. We're going to highlight these, and we're just going to go at a superficial layer of these, right? So the sympathetic and the parasympathetic nervous system. Let's start off with the sympathetic. So the sympathetic nervous system is like your body's emergency system, right? It kicks in when you're facing stress or danger. It's what triggers that fight or flight response. I'm sure you've heard of that. It prepares your body to take action in threatening situations. Also, like when you're scared or when you feel like you're in danger, or when you just need to be hyper focused. There are some situations that mimic the fight or flight and has nothing to do with you being in danger. It's just when people are aroused. So the best way to remember this is by associating sympathy with someone who's under a lot of stress, because that's when the sympathetic nervous system goes into full gear. On the flip side is the parasympathetic nervous system, right? And this is all about restoring your body to the state of calm and normal function. So this is a system that helps you recover after stress and relaxes your body after you've been through something intense. So it's oftentimes called the rest and digest system. So like the fight or flight in the previous system, this one would be rest and digest. They rhyme, so they do that on purpose. And that's because it helps your body focus on non-urgent functions like digestion and recovery. So if you're listening to this lecture, chances are you're in parasympathetic state right now, as it's about relaxation, maintenance of your body. And if I had any smooth jazz playing in the background, you would definitely be in parasympathetic state. Right? So think of sympathetic and parasympathetic systems working together to balance each other out. One for action and urgency, and the other for restoration and calm. So the word parasympathetic even comes from the prefix para, which means beside or alongside. So it works alongside the sympathetic system to keep things in check. So remember these two as a pair. Sympathetic, fight or flight, and parasympathetic, rest and digest. Wrap, as we say in the movie business. I hope this was nice, easy breakdown for you. The key takeaway with learning anatomy is to build that context so you can understand it, right? So you can get that big picture. The details they'll come in later when you take a deeper dive into anatomy and physiology. But go ahead and keep this overview in mind as that foundation, or at least categories where you can kind of now pin information to or add to. So we're halfway through the lectures for the week. Let's go ahead and move on to the next lecture, which is health and wellness. And looking forward to jumping into that material real soon, or in a few minutes, or a day or two, whenever you continue. And welcome back to Neurology, where we're going to cover health and wellness in this episode. Right. So in this episode, we're going to dive into what makes the nervous system work at its best, how everything functions when it's healthy, and then we'll switch gears and discuss what happens when things don't work quite right. So we'll touch on some diseases and conditions that can affect the nervous system and how they impact overall wellness. Okay, let's go ahead and get started. One more. Alrighty then, let's dive in. So the first key topic in this chapter is the neurological assessment. You're going to see some videos on neurological assessment in the face-to-face lectures. I have those ready for you. But let's go ahead and jump into this a little bit more. So in simple terms, it's a physical exam. It helps test how well someone's nervous system is functioning. You can usually get a pretty good sense if someone's neurologically intact just by observing them. Looking at things like coordination with their hands, their balance, and whether their speech is clear. You can also tell if they're alert and oriented to the surroundings, which is a big indicator of neurological health. So, like a physical exam, it goes deeper than that. So it helps identify even the smallest, sometimes real subtle issues that could be early signs of some bigger problem. Right? It's nothing complicated, by the way. The neurological exam is not some really advanced, you know, procedure. They're very, very basic uh, responses to a clinician's direction, and they're looking for some basic stuff. Again, it's designed to test coordination, sensation, balance, basic things, and these things are all crucial for the nervous system to work smoothly. You probably had some of these basic tests done before. Definitely when you were a newborn, you just probably don't remember that. But things like touching your pointer finger to your nose, then extending it out to your side. If some of you, I'm not saying anyone here has ever been pulled over for drinking, but I've only seen it on TV where police officers ask you to do that, like stand, put your hands out to your side, and touch your nose. It's basically a neurological exam. So they'll ask you to walk in a straight line, right, toe to heel, and that helps assess gait and balance. There's also something called mini mental status exam. So if you're curious, it's a quick way to assess a person's mental status, like their awareness of time, place, and person, and it helps catch things that go beyond the occasional forgetfulness, like writing the wrong year in January. So if you're still forgetting the year by June or July, that could be a big red flag. Um, and this exam usually takes only about 5 minutes. In fact, the video you're going to see in lecture is called the 5-minute neurological exam. All right, so let's continue on with this lecture. I was going to mention something about the date thing, right? Every time it goes to a new year, I'm one of those people who, and I don't know for whatever reason, I really stress the new year. So January 1st of this year, I'm always saying the year in my head to make sure I don't write the wrong year. I wouldn't want anyone to think that um, I need a neurological assessment. So a little bit of stress there. Dive into some neurological disorders, and I'm going to break them down into two main categories, right? Disorders of childhood and disorders of adulthood. And it's true that these conditions can occur at any point in life, but I've chosen to categorize them this way just for clarity. So, for example, brain tumors are more common in young children and older adults, but we're going to focus on them in childhood. Similarly, like cerebral vascular accidents, or what are called strokes, they can happen in both children and adults. But again, I'm going to only focus on their occurrence in adulthood. So let's go and start off with disorders of childhood. Okay, and the first one is anencephaly, right? Anencephaly, remember that the prefix "an" means without, right? And encephaly means brain. So this is a severe condition where a child is born missing a significant portion of their brain tissue. They may have some remnants of the brainstem or a small amount of brain tissue, but these children typically don't survive long, only for like hours, if not days, hours. And it's one of those incredibly difficult conditions, and it's one of the reasons um, that working in certain areas of medicine is pretty tough. The next term is cerebral palsy, right? So cerebral palsy, this occurs when like a child is deprived of oxygen during birth. So we often think of childbirth as challenging for the mother. It can also be very challenging and hard for the baby. So when a baby is deprived of oxygen during the delivery, it can lead to cerebral palsy, which is a neurological disorder that affects movement and muscle coordination. And the severity of the disorder depends on how long the baby was deprived of oxygen, which is why the effects can range from something very mild to something very severe in different children. The next term is hydrocephalus. Right? It's a condition where there's too much cerebral spinal fluid, too much CSF in the brain, and this causes the head to swell. The term comes from hydro, right? Hydro, and that means water, and cephalus, which means head. So all that excess fluid can cause pressure on the brain, and it leads to various neurological issues. The treatment typically involves draining the excess fluid, often through some surgical implanted shunt. So again, each of these disorders, they present unique challenges, and while they're more commonly seen in children, some can occur across the lifespan of an individual. But again, we're just focusing on the part of the childhood condition. Now let's go ahead and now shift into a new gear and talk about neurological issues that tend to appear more frequently in adulthood next. Hydrocephalus, right? This is a condition where children are born with an abnormality that causes their ventricles, right, that fluid-filled space in the brain, to produce too much CSF, too much cerebral spinal fluid. If you recall from the earlier discussion on the skeletal system, right, babies are born with what are called fontanelles, those soft spots in the skull where the bones they haven't really fused yet. So this flexibility allows the skull to expand as the brain goes rapidly during those first few years of life. However, with children who are hydrocephalic, who have hydrocephalus, that excess CSF and the excess cerebral spinal fluid, I'm sorry, I'm saying the abbreviations and the word as so help you remember it. So that excess CSF, all that puts pressure on the cranium and it causes the head to enlarge abnormally. So babies already have a large head in proportion to the body, but a baby with hydrocephalus, the head size becomes excessively enlarged, and this happens because the skull bones are still flexible enough to expand in response to all that pressure from the extra fluid. You got a good picture in your textbook, and so I have this picture here on the presentation, but there are better pictures in the textbook. You can compare a normal size head for a baby to a baby with hydrocephalus. Right? The treatment that they provide for a baby with hydrocephalus involves, shunting off that excess fluid, usually through the insertion of a shunt, right? And what that is, it's a way to drain that CSF away from the brain, and it just helps relieve the pressure and it prevents damage. So while you can't stop the ventricles from making more CSF, the shunt helps manage the overflow, the condition that allows for that normal brain development. So this is a condition that requires careful monitoring, intervention, especially in early childhood when the brain development is so crucial. It happens in adults as well. In fact, I know some adults who have this and have that shunt, and you can see it from, um, you can see it. Um, and that's all. I'm just saying it can happen in adults as well. Neural tube defects. I'm going to work really hard at enunciating. Neural tube defects. So neural tube defects, these are abnormalities that occur during the first trimester of pregnancy. Typically while the neural tube is still forming. Okay, trying to enunciate correctly is causing me to not enunciate correctly. The neural tube, right? This is the precursor to the central nervous system, right? It includes the brain, the spinal cord, if you remember that. And when something goes wrong during the development, it can lead to defects. And that can include anything that involves like the meninges, those protective layers around the spinal cord, or even the spinal cord itself if it got past the meninges, right? So these are two main types of neural tube defects. One is called a meningeal seal, and again, meningeal refers to the meninges, those protective layers surrounding the central nervous system. Again, I repeat, I repeat what I say over and over again for your benefit. The suffix cele, C-E-L-E, that just means hernia or refers to hernia or protrusion, right? So a meningeocele is a condition where only the meninges protrude through an opening in the vertebrae, the bones of the spine. And the spinal cord itself, it's not involved, but the meninges, they form like a sac-like structure, and it's visible. You can see it from outside the body. We have something called a meningeomyocele. This is a much larger word, but you can break this down just like before with the previous word. Meningeal still refers to meninge. Myelo refers to the spinal cord now, and cele, C-E-L-E, refers to herniation or protrusion. So putting all that together, right, we say a meningeomyocele is like a more severe type of defect where both the meninges and the spinal cord are protruding through the opening in the vertebrae. So this type of neural tube defect can cause more significant neurological impairments. And it depends on the location and size of the hernia. But both conditions are serious. They require surgical intervention shortly after birth, right? And this is to help protect the exposed tissues that are protruding. Right? What else? That's all. The defects underscore the importance of early prenatal care, right? Some can be detected during routine screenings, and they can be prevented or managed if they're detected early enough with appropriate intervention. So it's important to make those appointments, and make the meetings, make the appointments, not make the appointments to, you know what I'm saying, to show up at your appointments. There you go. Okay, so let's look at an illustration of a neural tube defect. So here we got an illustration that just kind of help you visualize what we discussed. So you see here in the picture that you can see the meninges, the protective layer surrounding the brain and the spinal cord, and the cerebral spinal fluid. I know it's just like a cartoonish drawing, but all of that's protruding out of the vertebral column. And this herniation forms that sac that you see there, which is typically the case in a meningeocele. Further up, you see a second illustration where you can see the spinal cord itself. It's also part of the protrusion. And here it represents the meningomyocele. Excuse me. Whew. And so in both of these, the meninges and the spinal cord are herniated outside of the body. And so the degree of neurological deficits depends on where that hernia is actually located. So the higher up the spinal cord the defect occurs, the more severe the neurological impairments are going to be. So for example, herniation higher in the spine may affect motor functions and sensation in the arms, neck, or even the respiratory system. And the degree of protrusion is another thing we look at, the layer of herniation, so what's actually protruding, right? So the larger protrusion, the more protrusion may involve more of the spinal cord, and that may lead to more significant deficits in movement, sensation, and other bodily functions. So in this particular case, the observation does provide a good predictor of what can happen. So looking at an illustration like this is a great way to understand what a neural tube defect can look like, and the varying severities depending on the size and location of the hernia. I was going to put an actual photo, and I thought, no, just leave it at the drawing, right? And again, early intervention and surgical management are actually crucial for helping minimize the neurological impact of these conditions. Okay, next we have brain tumors, right? So brain tumors are another important neurological concern. Your textbook includes a detailed table outlining various types of brain tumors. So although brain tumors, they can occur at any point throughout a person's lifespan, they are more common in childhood and in older adults. So in children, brain tumors may be linked to developmental factors, and some types are more prevalent like in younger children than in adults. And these tumors can affect various areas of the brain. So their effects can vary depending on their size or location, whether they're benign or malignant. So brain tumors in adults are typically linked to factors like aging, lifestyle, or environmental influences. In children, tumors tend to occur more due to like genetic conditions or they may just develop spontaneously. So it's essential, again, just to be aware of the symptoms and diagnostic techniques for detecting brain tumors. Not that you'll be doing any diagnostics on that, but in general, it's important to have these things looked at early. So early intervention, like with anything, it makes the biggest difference in the treatment outcomes. So you can go to your textbook and get more detail about specific types of brain tumors. I won't be uh, giving you a quiz or an exam on all the different ones. Concept we're going to cover is cerebrovascular accident, CVA, right? Otherwise known as a stroke. So for adults, one of the most significant neurological events is a cerebrovascular accident, or CVA, right? They're commonly known as a stroke. In the medical field, you avoid using the term stroke and refer to it as a CVA. This occurs when you have an interruption of blood flow to a portion of the brain. We're going to be repeating some of these conditions as well when we talk about cardiovascular, hematology, and so forth. So this is not the first time we're gonna be talking about cardiovascular accidents or stroke. I'll be saying stroke as well. So there are two causes. One of them is ischemic, and the other one is hemorrhagic. When you have an ischemic event, if you remember what the word means, right? This occurs when something blocks the blood flow, and this could be a blood clot or it could be a plaque that's become like dislodged and it obstructs the artery. What happens is it prevents blood from reaching certain areas of the brain. The next one is the hemorrhagic event. So this involves bleeding within the brain. So it can disrupt, again, normal brain function, and the bleeding causes damage to brain tissue. It deprives it of oxygen. But in both of these cases, when brain tissue doesn't get enough oxygen, those affected cells, they begin to die. And the location and extent of tissue damage just determines the deficits or impairments that a person might experience after a stroke. So it depends on where it is and how long you've been exposed to it. So one person with a stroke is going to present with different outcomes as another one, as somebody else, from somebody else, excuse me. All right, so what are potential symptoms and effects of a stroke? And I got this little picture here that I like, taking steps to reduce the likelihood of a CVA. I'm not going to go over that, but I'm going to go over the terms here: aphasia, dysphagia, hemiparesis, and hemiplegia. So aphasia, this is a condition it impairs the ability to communicate. Uh, it can uh, it can be what's called expressive aphasia, where a person can't express themselves, or receptive aphasia, where they can't understand what's being said to them. Everyone experiences expressive aphasia occasionally when you can't find the words you need in a conversation, which sometimes it feels like I'm experiencing it quite often as I'm talking. Um, in my mind, there's a lot of information flowing around, and I'm sort of like just grabbing a piece of information and giving you the trivia about it. The next term is, and then sometimes I say, okay, stop reaching for trivia and then move on to the next term. Dysphagia, right? This is a term that refers to difficulty with swallowing. Not speaking, but swallowing. So the prefix dys, right, means broken or difficult, and so this is difficult or broken swallowing. So dysphagia refers to, uh, sorry, dysphagia, G, refers to uh, not being able to swallow. And then the next one, dysphagia, I know they sound the same. Dysphasia, I'll say it like that, dysphasia refers to difficulty with speech. Right? Dysphagia, I'm gonna mispronounce it, but to enunciate the difference in the spelling, dysphagia refers to difficulty with swallowing, and dysphasia refers to difficulty with speech. So the two terms sound very, very similar. So when you hear it in context and being spoken, you should be able to distinguish between the two. Dysphagia relates to eating and swallowing, and dysphasia involves speech and issues. All right. Hemiparesis. Hemi means half, and paresis just means weakness. So hemiparesis refers to weakness on one side of the body. So if someone experiences a right-sided CVA, you should know what that is already. They might experience left-sided hemiparesis. Right? Uh, so by now, I should be able to say that sentence, and you should actually be able to put together what I'm saying. So the severity of a CVA. This can also lead to hemiplegia. right? And that's where one side of the body becomes paralyzed, so it's unable to move. These are just a few potential symptoms and deficits that can arise from a stroke, otherwise known as a CVA, or I will say preferably uh, instead of otherwise known as, preferably known as a CVA. There you go. And as always, early detection and treatment are essential for reducing the severity and the impact, and it helps improve your recovery. Improves your recovery. It helps improve your recovery time. Yeah, that's good. Let's talk about neurological disorders in adulthood. Right? So we're going to talk about things like encephalitis, meningitis, epilepsy, and radiculopathy. Right? Radiculopathy isn't a disease of someone making ridiculous jokes, but it could be, right? It's like, my dad's got radiculopathy. He makes all these ridiculous jokes. He got a disease where he thinks he's funny. That is not radiculopathy, okay? All right, I better stop saying that because I'm probably gonna put information in your head that it's gonna mess you up on the test. So let's talk about encephalitis. Right, this refers to inflammation, infection of the brain, and it's often caused by viruses, bacteria, or other pathogens. And it can cause symptoms like being confused, fever. Usually, when you have inflammation, you have an infection, and you have a fever, right? Meningitis is another inflammation. Again, it's an infection of the meninges, which I'm repeating myself, the protective membranes of the brain and spinal cord. And this can be caused by bacteria, by viruses, or fungi, excuse me, F-U-N-G-I, it's pronounced fungi. I say fungi because of a joke. It's like, I forgot how the joke goes. There's something like something where fungi, and then the person's supposed to say, no, you're a fungi, like a fun version. All right, which is not a symptom of radiculopathy. I guess that would be ridiculopathy, R-I-D-I-C-U-L. He's ridiculopathy. He makes jokes that only he thinks is funny. All right, the next one is, I'm going off topic. This is a really long lecture. I'm starting to go on side topics here. Epilepsy, right? Epilepsy is a neurological disorder. It's characterized by seizures. That's the most common symptom that it presents. And it occurs when like the brain's electrical activity becomes disrupted. So it doesn't become synchronous. And it's just chaotic. You have neurons, nerve cells. They transmit signals in a coordinated fashion. But when you have epilepsy, the signals become disordered and they become out of sync, and that just leads to like chaotic movement. And so it presents itself as a seizure. Right? The next term is pre-ictal phase. That I want to talk about here, and this is in relation to epilepsy, right? So kind of breaking down epilepsy into a few smaller pieces. There you go. So within the pre-ictal phase of epilepsy, again, and that means pre meaning before, so it's before the seizure, some people experience a sensation known as aura. Right? And so this can serve as like a warning sign, alerting a person that a seizure is imminent. There are, what do you call those? Not therapy dogs, but there are animals like that are trained specifically to pick something up, and I don't know what they're trained for, but they can tell when like their owner is about to go into a seizure, and they're trained for this. Um, and I just brought up a topic that I don't know very much about, but at least I can make you aware that those animals exist. All right, the next one is the next phase is called the ictal phase, and this refers to the actual seizure itself. And these are they're different types of seizures, right? Your textbook describes several in detail, and so just you can go there for more information. I won't be testing you or quizzing you on it, but I just want you to be aware of these larger concepts. There's also the post-ictal phase, and that's again post-after. So that's after the seizure, and the individuals present with things like mental fogginess, they're tired, or they'll experience physical symptoms of just being out of it, I guess. So this phase tends to last hours, right? It can be as short as minutes. You hope, but it'll tend to last hours, and the person just doesn't feel very well. Uh, they can't go back to their normal activities immediately. So it's I don't know how to explain it. Not that I've experienced it myself, but the way I've read about it, and I hate to make some references to like being on when you're on like a really groggy medication, if you've ever taken that and you're just it just knocks you out and you're finally waking up from it, or you're trying to get back to maybe walking around the house and doing some, things around the house, cleaning. It's still very difficult to coordinate and do all that. That's what I'm getting that it is like. All right. And the last term here was radiculopathy, not radiculopathy, as I've made so many bad jokes about that. This refers to disease or disorders that affect the spinal nerve roots, usually by compression, right? It's due to something that's herniated or a slip disc, slip vertebral disc. And this tends to cause a lot of pain in the patient, also weakness because of the compression of the nerve, and it also presents with numbness in the affected area. So a patient they may still have reflexes, they may still have motor control function, where let's say where they can move their hands and their fingers, but they may not feel the sensation uh, in that arm, so or in that periphery. Right? So a common one is sciatica, and so you hear. I know like quite a few people who have mentioned that they have a sciatic nerve compression, right? And that's the one that runs in the lower back through the butt and down the legs, right? So that happens when that nerve is compressed. It tends to cause pain, tingling, numbness along the path of the nerve, along the entire path, but that thing branches off to a bunch of things, right? And so if you look at an illustration in a textbook, it'll show you that sciatic nerve, how it runs through the lower back and into the leg. Um, Interesting thing is that for treatment, I know one of the things they do for treatment is injections with steroids, right? To reduce inflammation, to reduce the compression on the nerve, and um, it works great the first time, maybe the first 2 times. But what I've been told is that um, it loses its efficacy after a certain amount of time. They'll go back to the doctor, they'll get an injection, and instead of being good for like 6 months, it's only good for like a month, and then they're right back into pain. So it just starts losing its potency. I wouldn't say potency, but its efficacy. It's just so you spiral into this thing where you're in pain consistently. And let's go ahead and jump into some neurological conditions. Neuropathy, just a general term that means disease of the nerves. It doesn't specify the exact cause or nature of the nerve disease. It just simply indicates that there is some dysfunction or some damage to the nerve. Neuropathy can manifest in many different forms. It can affect sensation, motor control, even the autonomic functions, depending on which nerves are impacted. The next one here is neuralgia, and neuralgia just refers to nerve pain, right? Algia refers to pain. It's a combining form, refers to the nerve, so nerve pain. And so essentially it just means you have pain in your nerves, right? If you had pain in a cervical nerve, like in your neck, you could literally say something is a pain in your neck. I don't know. That was an attempt at a joke at the last minute and didn't turn out very well. But neuralgia, right? It can occur due to various causes like nerve injury, infection, or as a side effect of some medication. Um, and one of the most common types of neuralgia is what's called trigeminal neuralgia, and this causes severe stabbing pain along the trigeminal nerve in the face. So this is a very specific nerve that it's affecting. All right, the next term is paresthesias. This refers to abnormal sensations that occurs alongside normal sensations, right? So abnormal sensations that occur alongside normal sensations. I'm enunciating that slowly because I want to make sure you understand what I'm saying. So again, para means alongside, esthesio means sensation, right? And it can manifest in tingling, the pins and needles people say they feel like when their hand falls asleep, or just like a feeling of numbness, and it involves very uncomfortable sensations. I think you might be able to relate to this one if you've ever fallen asleep on your arm and you have problems moving it, you get the pins and needles, the blood flowing right back to it, and you're starting to get that sensation back. That is a horrible feeling. All right. Yeah, that tends to be a common example of paresthesia. Right? You sleep on your arm awkwardly. I still don't know like what position. I've gotten that before, and I can't remember now. Like, was I sleeping on my shoulder and putting pressure on my arm? And because I never want to sleep like that again. But once in a while, I just fall asleep, and I fall asleep in that position, whatever it is, and then you wake up and your hand's asleep. It's like son of a gun. All right, let's go and move on to the next thing. I'm going to start getting off topic. Chronic paresthesia, right? So not just having paresthesia, but having chronic paresthesia, and chronic just means over time. Um, this can occur if you have certain diseases. So this is not going to be something where you just slept on your arm. You're getting the pins and needles, you're shaking it, and it's coming back, and in a few minutes you're back to normal. This is chronic, it's taking months, and it's progressing. So people with like people who are diabetes, people with diabetes, right, will have something called diabetic neuropathy. Whew. All right. This can also be caused, like chronic paresthesia can also be caused by multiple sclerosis. What happens is it starts affecting the person's quality of life because they're not able to sense things as they usually would. And what happens, it just keeps getting worse and worse and worse. Right? This is also related to necrosis, and I'll tell you the link why, even though it's one's a circulatory issue and one is a nerve issue. So when you have neuropathy and you have numbness of the extremities, like your fingers and your toes, again, you're losing sensation. Let's say you step on a nail or you step on a piece of glass, you don't feel it, but you got a piece of glass stuck in the bottom of your foot. You might start feeling like a wet sensation or something, but you're losing sensation, so you don't know what's going on there until it gets really, really bad. And so that's the neuropathy part. The necrosis happens when because you don't recognize the pain right away, and it's gone for a while, that it might get infected, tissue might start dying, and so you start developing necrosis on the extremities because of that. One leading to the other, right? So paresthesia, specifically chronic paresthesia, leading to necrosis. Alrighty, so this sounds like we're wrapping up a comprehensive look at neurological health and wellness. We've been covering a wide range of conditions, symptoms, looking at a lot of terminology in this chapter. So even though this is like just another med-term chapter like all the other ones, it still feels like we've covered way more just because of the subject and the minutiae and the detail that are involved with the nervous system and neurology. So the next step is just to become focused on understanding procedures, things that will be uh, used later on to build like a foundational knowledge for whatever profession you decide to get into. So let's go ahead and jump in to procedures on the next section. Thank you very much for your time. And, oh, son of a gun. What does Jim Carrey say? Alrighty then, let's dive into the procedures related to neurology. If you're wondering about that image there on the slide, that's the image that the PowerPoint actually generated automatically. I leave them. If it's something that will get your attention to look at the slide, I just leave it there. It may have nothing to do with the topic, but that's like, okay, that's an attention grabber. All right, so let's get into neurological procedures. So let's talk about diagnosing, treatment, monitoring neurologic conditions. So a common procedure might be something like a lumbar puncture or spinal tap, right? This is where they they extract cerebral spinal fluid, CSF, and they do this for testing. Right. It's very helpful for diagnosing conditions like meningitis, multiple sclerosis, certain cancers. And also like looking at relieving pressure when you have an abnormal amount of CSF in the spinal cavity, right? The next term is electroencephalography. I'm talking about these and I haven't gotten to the slide yet. Okay, you know what? Let me go on to the next slide. Let me just tell you some of the things that we can talk about. I'm not actually going to talk about all these. I have a whole list here. Electroencephalography, magnetic resonance imaging, CT scans. We'll mention those. I think I meant to put these on the definitions in the glossary for the lecture. Electromyography, we mentioned that's a procedure for measuring the electrical activity of the nerve. Carotid ultrasound, cerebral angiography. There's a whole bunch of procedures that I looked up, but I'm not actually going to talk about all these. So yeah, I'm sorry. I did not a lot of research. I just looked up a whole bunch of common procedures, neuropsychological testing, assessments. Yeah. Let's go ahead and go to the next slide. You're basically hearing me talk about something you can't see. All right. So here are some important surgical procedures. Right. So we broke these down by these areas. So surgical, and the first one is craniotomy. Right. So this is kind of like now the lecture is a little bit more in line with medical terminology, medical words, where craniotomy is a surgical procedure where you make an incision in the skull and you're trying to access the brain. Nothing new though. We've had evidence of this being done all the way back to like Mesopotamia, like thousands of years BC, like 5000 BC, and records of it like being written down. These procedures being written down. So it seems to be like a really common procedure, even for the old days. But today it's used for like brain tumors, brain bleeds, and it's used to treat conditions like if you had a traumatic brain injury or if you had epilepsy. And the next one is discectomy. Right? This is a procedure that's done when there's a herniated disc, uh, and it tends to be in the cervical or the lumbar area. The goal is to remove part of the herniated disc that's pressing on the spinal cord or the nerves, and this helps alleviate pain and it helps prevent further nerve damage. The next term is laminectomy, and in this surgery, the lamina, which is the back part of the vertebrae, this is removed to relieve pressure on the spinal cord or the nerves. It's done in combination with a discectomy or for that herniated disc, but it focuses on reducing compression caused by the vertebra itself. And the next one, I'll try not to make a bad joke, but rhizotomy, right? There's a singer named Rizzo, right? And you guys can't answer me. If you answer me, I won't be able to hear you. I'm not into pop music right now. I wouldn't be able to tell you if that's real or not, or I think I just made that up. Or if it was like a fictional character in some TV show. But Rizzo sounds like a singer. Anyway, if it was rhizotomy, then we'd be actually making an opening. No, rhizotomy would be stabbing somebody named Rizzo, if that was an actual person. And you're probably listening to this thing right now saying, what the heck is the instructor talking about? I just got sidetracked with, there's a singer name. Lizzo, not Rizzo. Okay, forget it. Yeah, I got confused with another singer. All right, this is rhizotomy, a procedure where small portions of the spinal nerve roots are they're severed. We do this on purpose to disrupt pain signals. We use it when we have to treat chronic pain conditions that are just not going to go away. There's no other way of treating them, right? Medications won't work. Morphine and all that stuff won't work. It'll cause more damage than it would help. Um, the next one is ventriculoperitoneal shunt. I don't think I should make y'all write these fill in the blanks. Yeah, a VP. So we just say a VP, right? A VP shunt. It's used to treat hydrocephalus, and what it does, it drains excess cerebral spinal fluid from the brain's ventricles, and it does this by draining it into the abdominal cavity or the peritoneum. And what this does is it helps reduce that pressure that's caused by too much fluid in the brain. We use the abdominal cavity and the peritoneum for dialysis as well, but then we later on have to manually drain that. So I don't know if we manually drain cerebral spinal fluid that's being collected in the peritoneum. Maybe it's so little that it doesn't matter. It isn't a lot. All right. The next one is ventriculostomy. Ventriculostomy is a procedure where you make a small hole, a surgical hole, into the ventricles of the brain to relieve that pressure. And it's done in cases where you have like traumatic brain injury, and it's done to help reduce swelling. It's done to help prevent brain damage due to increased intracranial pressure, right? So that you won't develop brain damage. But not like a VP shunt. What a ventriculostomy is, it's temporary and it's just used to manage some acute condition. Right? And so these procedures that we talk about here, they all play a crucial role managing neurological conditions, everything from reducing pressure or repairing nerve damage to making sure that the brain and the nervous system function optimally. So hopefully you'll get more when you're doing your exercises and homework and as you're pouring through the literature as you try to answer questions for your exercises. Alrighty then, let's continue with the neurological exam. And what a neurological exam is a thorough assessment. It looks at various aspects of the nervous system to evaluate a patient's neurological health. And it'll include things like your history, right? Your mini mental status exam, your cranial nerves, looking at cranial nerves, motor system, deep tendon reflexes, sensation, cerebellum, and all this. Let's go ahead and jump into each one of these in a little bit more detail. All right, so when we're looking at the history, the healthcare provider, your doctor, nurse, whatever, they're going to take a history of any previous neurological issues, symptoms, or conditions that you may have been experiencing. And what this does, it helps determine if there are any ongoing or past problems that could impact your current exam. The, as we said, the mini mental status exam, the MMSE, again, it's just a tool to assess like cognitive function. This will include things like memory, orientation, attention, language, the ability to follow simple commands, and it's used to detect early signs of cognitive decline or neurological diseases like dementia. You're going to watch a video in class, and it's a 5-minute exam. It's on the course shell, and the doctor does a full examination with, I'm guessing, another doctor who's playing the patient, and they're walking you through all of that, and you'll see all the directions that he's giving and so forth. Um, Cranial nerves. So again, we mentioned there's 12 cranial nerves, and each one has a very specific function, like for vision, for hearing, for facial movements. All right, one for taste. So during the exam, the practitioner is going to assess the function of the nerves, and what they'll do is they'll give you various tests, like they'll ask you to move your eyes, they'll ask you to smile, they'll ask you to like puff out your cheeks, and you're thinking, what the heck are they doing? They're actually each one of these they're testing a nerve. Can you do it or can you not do it? And if you can't, they say, wow, like they can point to a specific nerve that you have damage to, or that's might be compromised. I'll say compromised. All right, the motor system. This is also part of the exam, and they'll check for strength, coordination, and muscle tone. You might have seen this like in maybe not movies or TV shows where the doctor is like he grabs the patient's hands and he'll say, or she'll say, pull away from me as hard as you can. Now push toward me as hard as you can. Try to pull my hands apart, just to assess like some basic strength and stuff like that. So uh, the provider, will observe the movement in the arms, legs, face, and they'll look for things, signs of any kind of weakness, tremors, if the patient's actually like struggling, even just to, you know, push against the doctor. And so, yeah, they're looking for motor impairments just by doing all those things. When they say walk, this straight line, heel to toe, they're looking for coordination, push against my hand, pull against my hand, whatever, all that stuff. It's like they're testing and they're looking for a very specific issue with a nerve. And as you pass them all, and they say, "Oh, you're good," um, and you go through it and you think, "What was that all about?" And that's what they're doing. And as you learn the functions of each one of the cranial nerves, um, you'll start understanding and linking some of those just basic tests that they do to something, physiological. So they're really looking at something deeper with something very, very simple to do. All right, let's keep going. Next one is deep tendon reflexes, and this is where like the provider will do use a reflex hammer, right? They'll top on areas like the knee, the patellar reflex, or to check for the patellar reflex, and they'll do the inner elbow to look for the bicep reflex. Again, all of this is on the video in the course shell. And what they're doing here is they're looking for response or no response, right? And to help assess whether you have functioning nerves and a functioning spinal cord. So they're looking for these arc reflexes. What else? They're looking for sensation. So what happens is the provider checks to see if the patient can feel different sensations. So they'll do like a light touch, a sharp touch, not like a super sharp touch, but a difference between like a very soft, blunt touch, like the end of a very soft Q-tip to the edge of a like your pen, like your writing pen. Obviously, they feel different, right? And so it's like that. Like one is definitely more edgier, sharper, and then one is definitely softer. And so they're trying to assess whether you can tell the difference between the sensation like that. They're not gonna like stab you with a pin, like an actual needle. Whatever. It's like, you feel that? Yeah. All right. And so they're just looking at for sensation, right? Oh, temperature too. Yeah. And again, all that's in the video. Cerebellum, how do they do this? So remember that the cerebellum is responsible for balance and coordination. And so you can kind of get an idea of what they do when they're testing the cerebellum. So what the doctor may do is ask the patient to perform a task like stand on one leg or walk in a straight line or touch their nose with their fingers, kind of like what they do for the alcohol sobriety thing that they do when they pull people over. And what this does, it helps the doctor assess the condition of the brain, the nervous system, and it can identify possible issues like nerve damage, weakness, sensory loss, or imbalance. Now, if you get pulled over by a police officer and you have these things and you don't know it, well, you're going to find out the hard way. They may think that you're drunk and they arrest you, and it comes to find out that no, you don't drink, but you have nerve damage, and that's why you didn't pass the test. So, go see your doctor. Um, yeah. So, um, that's it for these specific tests. Let's go ahead and move on to the next slide. What are we on? 38? Oh, we're almost done. All righty then. We are actually almost done. Let's talk about diagnostic procedures now. So these are procedures that are related to identifying, evaluating various conditions. So the first one is myelography. And again, graphy, right? We know that that means procedure, as where gram refers to like a picture. So a myelogram and a myelography are two different words that mean two distinct different things. One is the process for taking a myelogram. So myelography, it's the diagnostic imaging procedure. And when I say imaging, it doesn't necessarily mean like an X-ray. In this case, it does, but it doesn't necessarily mean an X-ray or a picture, like a photo kind of thing. It could also mean, if the prefix is correct, it can mean like an electrical picture of the heart. What does the signal look like? But in this case, it is an image, right? Just to be clear. So they use it to examine the spinal cord, the nerve roots, and what they do is they'll inject a contrast dye that's injected into the spinal canal, and they do this through a lumbar puncture. Right? So lumbar punctures are not just to, centesis, not just to pull out cerebrospinal fluid. They can also inject dye. And then you get the X-ray or the CT scan, and they do this to visualize to increase the contrast, so you can visualize the spinal cord, nerve roots, and all the surrounding structures, because the dye tends to absorb into the tissue, and you can see it better. Right? And they'll use it to diagnose conditions like herniated discs, spinal tumors, and nerve compressions. I remember that they not remember because I don't think I mentioned this. X-ray kind of goes right through tissue, and it gets absorbed by hard tissue like bone. So if you're trying to image soft tissue, X-ray is not the best way to go, but if it's the only way you have, there's procedures to do this. All right, so doing an X-ray with a contrast agent. Now we have the alpha fetoprotein, AFP, right? This is a protein that the liver makes. So it's produced by a fetus. Sorry. It's AFP is produced by, because it's fetoprotein. It's a protein that's produced by a developing fetus's liver. And they look at the levels of this protein, right? So the levels can be measured throughout pregnancy, And if you tend to have, not tend to, if you have like an elevated AFP, um, and this is detected through like amniocentesis, right? So they'll get amniotic fluid through centesis, right? So it's withdrawing amniotic fluid. This could indicate that you have, or the baby is having a neurotube defect, right? Doesn't necessarily mean it does, but it's like, okay, this points to that. It could be anything like a meningeal seal or the meningeal myocele that we discussed in a couple of slides ago or a couple of sections ago. Again, abnormalities in the spinal cord and in brain development. And if you can detect these early enough, you can treat for these early enough. The next one is electroencephalography, right? EEG. So it says the word electro in front of it, right? So you know it has something to do with electricity. Graphy means an image. So electroencephalography, this just means that we're taking an electrical image of the brain, right? So it's used for diagnosing seizure disorders like epilepsy. So during the test, they'll put, I think you've seen movies where they have all those electrodes on someone's scalp. Right? So the electrodes are placed on the scalp. They detect brain signals and patterns, and this helps the physician assess how neurons are firing and identifies any irregular activity that might be associated with seizures. Right? We know what a normal brain signal should look like, what normal wave patterns should look like, the frequencies, the amplitudes, in someone who's healthy and not presenting with any of these disorders. So we have something to compare it to. The next one is polysomnography. Right, and this is what they do in sleep studies, right? To diagnose sleep disorders. Things like the one you're probably more familiar with is sleep apnea. Narcolepsy is another one. I knew one person with narcolepsy, which was amazing. He could sleep standing up. He could just be standing, talking, and he would fall asleep, and he would just stay asleep until you woke him up. He wouldn't fall down or anything. Anyway, I think it's interesting. Or restless leg syndrome, right? That's the other thing. So what they do during this study is they'll monitor functions of the patient while they're asleep. They'll monitor the brain activity, eye movement, muscle activity, heart rate, their breathing, and a lot more than that. And what this does, it helps the doctor understand the sleep patterns that a patient is going through throughout the night, and they use it to detect issues that could be disrupting the sleep, like so why someone's waking up 3 or 4 times a night and not getting a good night's sleep. So these diagnostic tests, they provide a lot of information to the physicians, and it enables them to detect abnormalities and diseases in the nervous system. Sorry, I'm looking at the recording thinking, did I hit record or was I just talking to myself this whole time? Yeah, so let's see. I think this is what? This is the last slide. All right, and this is the last slide. In other words, we're done with the entire lecture for this section. Again, I want to thank you very, very much. This is a very long lecture. There was a lot of little things to talk about, so you can only imagine what you're going to get in an A&P course if the medical terminology lecture was already this long. But I'm glad you made it. I'm glad you took the time to go through all these sections. Now what you need to do is go through the homework and the exercises. I'll put that little picture there for actual exercises because it's a good way to not prevent cerebrovascular accidents, but it helps to reduce the chances of having one. All right, so with that said, thank you very much, and I will see you on the next lecture, the next system.